My name is Chris Proulx. I am a Director of Clinical Education for Chattanooga in the United States and work with people like Karine and Francine and many folks, Cliff, that you probably have already been in contact with, have listened to, or work with. So my focus today is actually going to be on this, which will be the DTS system. So when we look at the treatment, there are some things to take into consideration. I still think it's very simple. It's very easy, to apply it. It doesn't have to be complicated, but you do have to take a few things into consideration, such as knowing the effects. You have to know your device. And so, if you can, well, I'll come to an open picture in a second here. But if you can see that there is a degree of resistance to the separation, that's an important concept. You need to know, what stage your patient is to understand, should I pull them hard? Should I pull them light? Should I pull them slow? Should I pull them fast, right? And that's going to match up with, we're going to cover, the different types of mobilization based on Maitland. So when we look at the other thing is today's mechanical traction technology. And even before that, let's just think about, this mentality, right? So the mentality is important because even in our description in the United States of that specific code says that we pull people very, very hard with a high degree of distraction force. Well, if I use that thought process and I'm treating patients that are very acute, they're not going to feel very good, right? Or when we look at the older protocols of 50% of body weight, and I'm on a split table like this, right? So this has a very low coefficient friction design to it, and that's very important when we look at this particular design, because that means we've obviated, we don't have to worry about body mass anymore. Right? So, and I usually do this trick where I sit on the table and I weigh about 108, 110 kilograms. And it takes the same force to separate the table, whether I'm on it or not, completely on it. And the reason is the design of the table removes the effects of gravity on body weight. So we don't use 50% of body weight anymore, right? Because that actually would pull someone with a much higher degree of distraction force on a split design table like this than it would on a treatment plinth. And that's where that came from, was two studies that was done in 1980 and 1981. And they used a table that didn't even split, let alone have a low coefficient of friction. We can also manage the hold patterns, right? We can hold a very, very short period of time. We can hold a long period of time all the way up to 99 seconds. So we really have an opportunity to determine, the type of hold pattern based on the benefit, right? Based on what it is that we would like to accomplish with the patient outcomes. We can also control the speed, right? And again, I start to remind people that, if you're working with clinicians or you are a clinician, what's your typical process when you're working with someone who's very acute compared to someone who's very chronic? Do we use the same manipulative procedures? Do we use the same mobilization procedures? And the answer is no, right? So we have different levels to that. And I'm going to use Maitland as an example. It can get a little bit more complicated than that. But if you are a manual therapist or, you're someone who's going to work with them, this is a really good connection because even I was resistant, right? When I was approached with this a few years ago, many years ago, I said, I use my hands predominantly because, traction doesn't work the way that I would like to address my patient's condition. Well, when we look at the platform, and there's a few different features to that that's very important, we can mimic, some of the things that we do with our hands, right? And so that was accomplished because of today's technology, which is very different than looking at it from 4,000 years ago, to where we know we could separate vertebrae, right? And that was actually established a long time ago. not with MRI, but it was established, on cadavers and has been utilized for a very, very long period of time to create separation in the vertebrae, right? So that's going to be separation in the articulation. And then from my standpoint, it's very important to me to look at the neurological effects, because I think that that's one of the big things that happens with people. You can see I've got some tools and things like that here that I'll come back to, and I'll talk to in a moment. Let me go back to my slides. So today's technology has dramatically improved our ability to mimic some of the things that we valued from a manual therapy standpoint, right? And so one of the things I left out, I'm going to show you here in a moment, is the securing systems. Even when I transitioned from, I had a DTS head and an older table, the 550. Some of you may know that and have it. Great table, but the enhancements to the table and the belting system also dramatically improved. And so when we look at the technology, it's both in the table designs themselves, but also in the traction devices and the microprocessing to how these things can work. I have an Active Track 3D as well, so I have multiple tables, and my preference is to use a line pulley table. I use my DTS systems pretty much all the time. In fact, my Active Track 3D is in another clinic that I only go to once a week, 2 weeks on, 1 week off, and so I don't use that nearly as much because I like the line pulleyed system for what it can accomplish, and we'll look at that here in a moment. Okay, so why DTS? Why not just a regular traction system? I won't spend a lot of time on this. I think it gets into a little bit too much detail, especially for salespeople. But know that this information is available, and it's important because it's I was very critical. It was one of the reasons that it got me more excited again, and it was very timely. It was very important to me because changing practice patterns, and especially today, many of us are dealing with this COVID situation, and we have a larger influx of patients, especially here in the U.S. in chiropractic, because the changes in the systems to where people can't go to their typical primary care system physician, and that's important because they tended to manage, a lot of musculoskeletal conditions. Like I said, that new patient I had just started with, that's where he went first because he'd never been to a chiropractor and never thought to go to a physical therapist, prior to that. So the DTS system, right, and not just the head, but the overall system, it has a very large connection to manual therapy, right? And traction historically also has that connection. Why was it established? Because it's hard. It's hard to pull on, someone's body. And, I used to work a lot in high-end athletes with, professional Olympians and university, and American football players, rugby players, tend to be very, very large people, and it's difficult, it's challenging to be able to accomplish. Manipulation is different, but mobilization is very challenging, and it's very, very physical, and it's difficult for the clinician to be able to, maintain that and continue that. So when we found this opportunity to sort of mimic Maitland, so Doctors Maitland and Kaltenborn and Syriacs and Manel, a lot of those have influenced the reasoning for the design of this particular platform. And they did a great job, because if you know anything about those particular practitioners and the history, of that in manual therapy, especially articulation manual therapy, we value that a great deal. There's a lot of really good things that we can do that we can't otherwise accomplish by any other means. And so I'll use Maitland to sort of look at this and define what exactly can we accomplish? What can we replicate? So when we look at, Maitland's grading criteria for mobilization, there's 5 different levels to it. So we've got 1, 2, 3, 4, and 5. So I'll go to grade 5 first is right? So that's your really rapid, high velocity, low amplitude manipulation, right? So we often call that manipulation. The others are going to be referred to as mobilization. So manipulation takes place at the end range of a joint, of an articulation, and even enters an area that otherwise we can't get to with other forms of manual therapy or mobilization. So we look at mobilization on those first 4, and typically grades 1 and grades 2 we think of as not at end range, not at high forces, not with a lot of combination of the high forces, high speeds, or at end range. And in fact, we indicate and we use our lower grades like a grade 1 or grade 2. So sometimes after a manipulation procedure, I'll perform a grade 1 or a grade 2 mobilization. Or for acute conditions, I'll perform a grade 1 or a grade 2 mobilization procedure to influence, a suppression in muscle activity, to enhance hemodynamics, decrease edema formation, mobilization in the tissue, exchange of synovial fluid, kind of a lot of the things that we talked about that traction can do, or spinal distraction from a mechanical standpoint can accomplish. And so when we look at these different grades, it's going to be where in the range of motion, the amount of range of motion, the oscillations, the amount of force, and the amount of speed, right? All those things that I can actually almost manipulate with my DTS system. Now, the difference in the DTS system is it's just axial. But remember that the first mobilization technique that we tend to do is called long axis traction, right? Long axis distraction. So we cannot replicate a grade 5, so a manipulation procedure with this, but I can actually do a lot of the other ones in that axial distraction plane. But with my line pulley system and with some of these other things, I can position a patient, right? So I use these blocks like gilets, mechanical blocking, orthopedic blocking for a patient while on distraction, as well as to preload certain positions or directions that I would like to enhance along with the axial distraction. And I was showing you something that you may not be able to see, so let me cut back to my video, right? So these are the wedges that I use for blocking, and we've got all different kinds of wedges and pillows. Even the bolster I use to position the patient appropriately for spinal distraction, which again, may have something to do with outcomes. But with a line pulley system, here's a teaser. This is the new belts. They're coming out very, very soon. They're fantastic, right? These are engineered, right? They're not just wrapping around a patient like we see with some of these other platforms. There's a reason for these, right? So this will attach down here. And when you look at this, you see 1 strap here, 2 straps here. 2 straps is always closest to the table, right? When I change the height of this table that connects to this O-ring, it changes the length of this belting system. Why does that matter? Well, because it changes the moment arm length, right? So it's physics. And what do I get with that? I get changes in the distraction force. So now I get a coupled motion effect. So when I have a patient who's in the supine position and I have an angle and the table's down, I can actually get a posterior pelvic tilt. If I want them in the prone position, I can get an anterior pelvic tilt. If I use blocks, I can get obliquity to the pelvis. If I change the position of the traction head, I can also change the direction of the force along with the distraction. So we actually have an ability to create a lot of coupled motions that otherwise we were not able to accomplish in some of these other devices. I'm going to go back to my share screen here. So we were able to change speed, forces, change the length of time, changing direction and forces. So you see where I'm going with this. I'm actually able to mimic a lot of things that people argue that why they don't like traction is we like to do manual therapy. Well, it's very difficult to do manual therapy on really, really big people for long periods of time, right? So this is just showing that we can create these distraction forces simply by, manipulating the patient's position. So we're always, the primary vector is going to be in the horizontal plane, and that's important because the table provides for that, but by changing the angle position, we get a different resultant vector, right? And as a result, we get different positions and forces that are going to be acting that create mobilization in other planes. So no longer is it just a straight axial, we're also getting mobility in the other areas. And that's why I like, using a line pulleyed system instead of, my other table, because the other table I position and I hold and then I distract, right? Instead of using a coupled motion effect, it's a little bit more effective, and it addresses the typical arthrokinematics, the way that a joint actually responds. So along with that, there's some presets, right? Your DTS pull patterns, 1, 2, 3, 4, and 5, right? I won't spend a lot of time on this. That'll be a discussion for another time if you're interested. But those are specifically designed to mimic some of these more popular manual therapy patterns and or spinal distraction patterns without me having to be there. So DTS pull pattern is a really good example to where I would hold and try to get to end range, and then I'm waiting. I'm waiting for two things. One is muscle activity to decrease to get to the connective tissue, and then I would like to create deformation to the connective tissue. Very difficult to accomplish, again, with your hands on a pelvis or, even using straps and things like that. Almost nearly impossible, especially to do that all day long on patients. DTS pull patterns, a hold and then a step down release. That's important again, because when we hold for really, really long periods of time, we do get this creep effect. You can create inflammation, right? We used to call that traction hangover, and some of the older devices would come with an electrotherapy unit to treat, people's discomfort after. DTS4, I love this one because in older adult patients with multiple levels of degeneration, we're not going to get a nucleus to suck back in and stay there, right? And so, especially with multiple levels, and we're trying to get mobilization in there. This one is a progressive stepwise approach. And again, we can control some of the parameters, including the amounts of forces and time in between those step patterns. And so again, I can really set it up to mimic something that I might normally do with my hands. And then this is your 0-0 hold pattern. So I can really mimic oscillations, and I can either use a low amount of force, and remember that the amount of force also determines the degree of separation and the point of range of motion, whether I'm at end range or I'm near the beginning, which is good for early phase, such as acute conditions, or if I'm looking for a mobilization technique a little bit later. So why add this, to my treatment regimen? So my personal experience has been as I've changed practice, I don't do as much manual therapy as I used to. It's very time consuming. It's not efficient in the clinic, especially if I can do some of that with something else that allows me to treat other patients or do something different, but also saves me, so I maintain my physical capacity to be able to treat patients throughout the entire day. So that's important to me because that's good for business. It allows me to treat more patients and treat more patients effectively because I'm not going to fatigue, especially being a a spine specialist, right? So we know the data on what it does. We know the research on, its effectiveness. We also know that the benefits of combining this with other therapies makes it a very, very powerful tool. And then we can also start to think about, in the clinical setting. So it's at a hospital group in a socialized, medical system, and there's people just lined up, outside the door, and a lot of spine conditions. Well, you need to treat a lot of patients, and so to have a device that can do some of that work for you really improves the overall efficiency, let alone, the potential opportunity that I can accomplish from a financial standpoint. So I always say that this doesn't completely replace my hands. And I always recommend, when we're building clinic in physical medicine, conservative medicine, manual therapy, if all I cared about was the tools, and I had them all, shockwave and radio pressure wave and lasers, I have 4 lasers, all that stuff. But if that was the only thing that made my clinic special and it wasn't me, then patients can go anywhere and theoretically get the same treatment. So I always recommend, there's still this. I'm still a manual therapist by training and by trade, and that's always something that I do. So when I look at everything that supports these hands, that's important, because I want to make sure that my patients are connected, to the practice and not just a machine, right? These are very, very important. They're part of the program. And I think that's another reason why, people don't always share the same success that some of us might, is because they don't put the appropriate mindset into the patients, and to understand that, this is just part of it. It's an extension of what I do with my hands and my brain, right? So it's important that, you still have some concept of what you need to accomplish with the patient. I don't think it's difficult. There's not 100 different protocols. There's like 5, right? And so what's going to be individualized is, the amount of forces, the position that we need to put the patient in, the number of treatments, and even then, it doesn't take a lot of thought process if you're a trained clinician. And again, that's important that we emphasize, what clinicians can do. So, we also have data that shows that this can enhance recovery. We've seen it, and why we use it, from a recovery standpoint in human performance, is how it influences, the human body in recovery, not only from an injury, but also from intense bouts of training. It also shares it's a very, very high patient satisfaction, right? And we're finding that in the data more important than ever, because people are better consumers of healthcare around the world, right? Many of you work in areas that have socialized medical systems, and so that's wonderful. But some people are also seeking out maybe a little bit better care, and they're willing to go to a clinic, that can provide that, and they will pay out of pocket for it, right? And so that's another thing I want to make sure that, our clinicians understand, is that, just implementing a machine, it doesn't take care of everything. So indications, and you can read these in the manuals, but I still get these questions. Anything spine, and probably anything shoulder, and anything hip. So when I treat shoulder patients, I use cervical distraction. When I treat hip patients, I use lumbar distraction. And it's, again, because of the adjacent structures and the coordination between some of those tissues and the overall movement patterns, we'll find is very, very important, let alone really anything from a spinal standpoint. For me, it's part of overall spine care regimen, right? Because I'm a manual therapist, and we do manual therapy. Well, this takes care of a lot of that. So the amount of manual therapy that I have to then do on patients after they do this is less, and it's easier, right? So I'm better at protecting myself, but as a result of doing a better job at protecting myself, I can actually treat more patients. So I can take better care of my community. The side effects are very similar to what we see in other manual therapy. The difference is it's very controlled, and we can start very conservatively and always add more. I find that I'm very conservative in my approach. And again, the data shows us that it doesn't require a whole lot of force to create a clinical significance, as well as a biomechanical or a physiological significance. And then also, I remind people of the potential side effects that you get from other approaches, right? And much more severe, you know, taking an opioid and even an over-the-counter NSAID for some people, right? And so not everyone can even take some of those types of medications. So contraindications, again, are going to be, you know, somewhat similar, but what I want to focus on is treatment precautions. You know, because we used to pull people very, very hard. We used to use really large forces, and we couldn't do that with acute neck pain and back pain. So it's a precaution because we want to make sure that, you know, we need to rule that out, and then that they don't have a fracture or anything that is a contraindication. But again, with this system, I can mimic a lot of what I would normally do with manual therapy. And then post-surgical procedures. They make actually some of our best patients. It's not a contraindication, right? I'm using less force on this machine than if I'm doing a manual therapy procedure. So it's not a contraindication. They make really, really, really good patients because many of them do not want to have surgical procedures again, right? So the sequence of events also can make a difference. So I use, you know, this approach to make sure that we can address the various components to the pathology of the patient. That also includes their patient satisfaction and their pain, right? Even though those aren't the primary, statistically speaking, they're going to be very, very important, right? And so mechanical traction does a really good job at doing a lot of the mobilization procedures that are going to be necessary and make it easier to move some of these detailed components that otherwise may be a little bit more challenging. I also do some exercises immediately following. So I have patients do some exercises because some of the neurology that we capitalized on in trying to stimulate things like the multifidi and the rotatories and core mobility movement patterns, we can actually do much better immediately following distraction before they become erect, before they become immobile again, right?